Welcome to lecture for psychopathology. I'll be talking this time about substance use disorders. So the first thing just kind of mention are the variety of classes of substance according to the DSM. and and like most things in the DSM, people may disagree about the classification system and if maybe there should be different categories, or if maybe there's too much overlap between some categories. But this is what we got, and you know what alcohol is: amphetamines. So that's your speed and uppers. Caffeine, we're all familiar with that. Cannabis is your marijuana. Cocaine is a stimulant that's different than amphetamines. Works primarily on the dopaminergic neuronal pathways. Hallucinogens include your mushrooms, LSD, but not PCP. See in a minute. Inhalants. So if they're huffing gas or paint or whatever. Nicotines and cigarettes. Opioids, that's your heroin. Phenylcyclidine, that's your PCP. And then lumped together are sedatives, hypnotics, and anxiolytics, or anxiety meds. Usually these are prescription drugs, Xanax, and other things that are usually used to sedate you, make you calm. People eventually abuse those. Okay, so these are the classes of substances. What can you get diagnosed with by using them? Well, a variety of things. Substance dependence, substance abuse, or one of the substance-induced disorders, right? Which, again, the DSM is not always that consistent, because some things that it has as disorders are very brief and state-like. And you can be diagnosed with alcohol intoxication, right? And does that seem like a mental disorder? Well, it does involve kind of psychological and physical impairment, but it is typically short-lived, right? Not high forever, but you can be diagnosed with it, and it's helpful to have that as a diagnosis. Just for communication purposes, in terms of being able to say, when they presented to the hospital, they met criteria for alcohol intoxication. Oh, okay, so that's why they were doing these things, right? So the diagnostic label provides an explanation for some behaviors, which is what it should do, and it shouldn't be used to say, oh, that's what type of person this is, and I think that's what we do with the other labels. But this kind of reminds us that no, it's just communicating about a set of behavior, and in this instance, a set of behavior that's fairly circumscribed in terms of time. Also substance withdrawal, or one of the substance-induced depression, substance-induced psychosis, a variety of other disorders, which we'll come back to. Let's start with the first one, substance dependence, referred to elsewhere as addiction. Remember, the DSM doesn't use the word addiction; it uses substance dependence, because they want to be different. Okay, so it's a maladaptive pattern of use. Substance use, right, characterized by 3 or more symptoms in a 12-month period. Right? So that means that if you start, using heroin, and use it every single day, and you steal stuff to use it, whatever, you can't meet criteria for dependence on it yet until you've done that for a year. Right? And probably the idea is that, well, people are going to experiment, and when they're experimenting, they may have some problems. But we don't consider it a disorder yet. We don't consider it like people who have done it for more than 12 months. And it's kind of like we draw this line saying, okay, if you experiment for a while, you got a year to do it in. Do it longer than that. Now, people that do it for a year or longer, we're saying are qualitatively different than people who do it for less than a year. And there's probably some truth to that in terms of the outcomes you would expect to see, and also maybe even the etiology of why people began using in the first place. Maybe it's different between people who get hooked and those who don't, right? But there seem to be different groups. So we have to have 12 months of kind of not a pattern of use. A long list of symptoms, right? Tolerance, which is you need more of the drug to get desired effect, or diminished effect with the same amount. And the second part you usually get if you can't afford more. You can't afford any more of the drug. But so you can only buy the same amount, but you get less high, you get less drunk, less stoned, whatever each time. So that's kind of that's a very biopsychological phenomenon, tolerance, right? So there is a big biological component to that in terms of neuronal transmission and downregulation of neurons, to where again, the body is all about homeostasis, as I said before, and if you are causing an effect artificially by some drug, the body's going to adjust to it and say, oh, well, there's this weird anomaly. There's more of this substance in our environment now. We must account for it and not overreact. Right? So your body's going to turn everything down, so you need more of the drug to get the same effect, because it's not a natural effect. Withdrawal, which is a syndrome characteristic of the drug used. And that just means that there's a pattern of symptoms, right, that's different depending on the drug you're using. And often the symptoms are the opposite of the symptoms you get when using the drug. Right? So if a drug maybe makes you really hyper and lots of motor activity, withdrawal may be the opposite, and kind of lethargy, and so not as much as with the drug, but now below normal. Because again, your body is reacting and going the other way, turning things down. So if you don't get the drug, now you can't be normal anymore. Your body's turned it down too much. And again, the pattern of symptoms differs across drug type, because again, it's largely driven by biological considerations. It may also involve the same or similar drugs used to relieve or avoid withdrawal symptoms. So you can meet criteria for kind of with withdrawal symptom, even if you aren't experiencing withdrawal symptoms. With the idea being that, well, maybe you're not experiencing withdrawal symptoms, but it's because you haven't quit. And one of the reasons you're not quitting is to avoid the withdrawal symptoms. Like, so you're still drinking alcohol, because when you don't, you get the shakes. Right? So if you're having to drink or use the substance to prevent withdrawal symptoms, that meets criteria for the symptom of withdrawal. Excuse me. Use of the substance more or longer than intended. So I'm just going to smoke this one joint, and then you do a whole bowl. Right? That would be a symptom of dependence. With again separating between kind of this idea of theoretical idea of controlled or recreational use and dependent use, where the whole core thing behind this is a loss of control around the use, right? Which you've got that written in one of the symptoms, and this really is the core symptom. And this symptom is often explained as, well, you can't quit, right? That being, how do you know you can't control your use? Well, you know you can't control it if you try to quit and you can't. People say, well, I have no desire to quit. I'm in perfect control, but I don't want to quit. It's like, oh, you're addicted to TV. Stop watching TV. I don't want to stop watching TV. So you're addicted. Kind of this circular argument. So it's hard to really kind of prove that piece until people do want to and try to quit, but can't. And that's why you have some of these other symptoms in there, and not just, oh, well, it's lack of control. Because you don't know if you have lack of control until you try to stop. So the other symptoms include things like lots of time spent getting the drug, using the drug, or recovering from the effects of the drug. Important activities being given up. And lastly, you keep using it even though it causes or worsens a physical or psychological condition. Right? So maybe you've got some paranoia, a little bit paranoid personality disorder, maybe some schizotypal, maybe schizophrenia, and whenever you smoke weed or use some substance, your paranoia gets worse. Maybe you add hallucinations, so it exacerbates the psychological condition. Or you have emphysema, and the more you smoke, the worse your emphysema gets, but you do it anyway, right? So when we look at those things, when we say, oh, look, you have a problem, you can't control use, I control it, I just don't want to quit. Well, clearly it's a problem because you're suffering these negative consequences. It's taking lots of time. You're giving up important things. You're using more than you intended, and you're physically hooked. You've got tolerance withdrawal. Right? So you got these other things, in addition to that, their own perception of loss of control that are indicators that they don't have control over their use and are unable to use in a recreational way, as many people maybe think that they are doing. Important to note here. So you need 3 symptoms, right? So 2 of the symptoms are the ones we often think about, tolerance withdrawal. But you've got, 1, 2, 3, 4, 5, 5 other symptoms here that don't include tolerance withdrawal, which means you can be diagnosed with substance dependence without meeting criteria for tolerance or withdrawal. Right? and often we talk about tolerance and withdrawal, defining physical addiction to a drug, and the other things being representative of physical and psychological addiction. So the idea being that you can be psychologically addicted to a drug without being physically dependent on it. To where if you stop using the drug, it's not going to cause withdrawal symptoms. You're not going to get sick. Not going to kill you, and you can use the same amount maybe every day. So you smoke the same number of cigarettes every day. But if you have these other things going on, you can still meet criteria for dependence, and that's important because drugs differ with regard to the level of physical addiction, right? Like for heroin, high physical addictive profile, right? Likely to develop tolerance withdrawal. Something like cannabis, less clear about that, whether or not withdrawal symptoms occur, or even tolerance, even in the presence of a problematic pattern of use that meets criteria for substance dependence. Okay. Excuse me. Another thing to note here is that you can't be diagnosed with dependence, abuse, all these things for every single class of drugs. Most of them it's true, but for dependence, for example, you cannot be diagnosed with caffeine dependence. All the other classifications you can. Alcohol, amphetamines, caffeine. Alcohol, amphetamines, cannabis, cocaine, hallucinogens, inhalants, yada yada. All those things you can be dependent on, but you cannot be diagnosed with caffeine dependence. For those of you who share my addiction, caffeine, if you ever try to go the day without drinking your coffee in the morning, do you develop a headache? If so, that's a withdrawal symptom, right? Do you find that sometimes you need to, maybe you started with just 1 cup of coffee a day, and then you've slowly increased to maybe 2, and then also a soda in the evening? Do you maybe drink more coffee than you intend to? Does it make you jittery when you drink a little too much? Right? If so, we start to say, well, Jesus, looks like some of the symptoms at least of dependence. So why can you not be diagnosed with caffeine dependence? Because everybody who wrote the criteria is probably dependent on caffeine, right? They're a bunch of coffee drinkers, and they just didn't think that needed to be in there. And typically, we don't see people knocking over liquor stores, to raise money to buy soda, right? And largely that's because caffeine is cheap, right? It's easy to afford as long as you don't go to Starbucks, and it's legal, right? So whether or not people develop problematic patterns of behavior around a substance is probably related in part to that substance itself and its kind of physical characteristics and what it does to your brain. But it's also related to kind of the social cultural context, right? Where if caffeine were illegal, it's possible people would start knocking over liquor stores to get it because it would be harder to get, it would be more expensive, So I think that's an interesting thing to think about the effects of a cultural setting on whether or not people develop a problematic pattern of behavior. Okay, you can tack. What's going on here? You can tack specifiers onto your diagnosis of dependence. With or without physiological dependence. So that's, our tolerance or withdrawal present. Either one of those present, it's evidence of a physical dependence. And sometimes that's important to know in terms of treatment and what you can expect for outcome. And then there are also course specifiers in terms of remission. Whenever you are starting to get better, you still have a diagnosis, you're just getting better. So you have early partial remission. So within the first year of you getting better, you now still meet 1 or more criteria of dependence, or this also applies to abuse, we'll talk about later, but not all. So not all 3 for dependence. Right? So you still have some problems, but you don't have all of the problems. And it's early partial remission, you're in the first year. And then sustained remission can be partial or full. Sustained means longer than 12 months, so obviously sustained partial remission, 12 months or more, where you don't meet full criteria, but you still meet some. And then sustained full remission is a good 12 months of meeting no criteria for the disorder. And why 12 months? It seemed like a good idea at the time. You know, they raised their hands and voted. Do we now kind of believe that if you've been sober for 12 months, you're good to go, and if it's less than 12 months, you're in the danger zone? No, not necessarily. Research hasn't borne that out. And how long people are sober for, and to where the danger of relapse decreases, depends greatly upon the substance we're talking about. So this kind of broad category that they're using in the DSM, maybe not that helpful. I mean, it tells you something about the person. Oh, they've been clean for 12 months now, but what does that really mean? We don't know. It depends on the substance, whether or not they seem really recovered or not. Substance dependence, we talked about now. Substance abuse is a maladaptive pattern of use leading to impairment or stress as shown by one symptom, just one, one symptom in a 12-month period. Okay, so again, not getting drunk one time or getting high one time and failing to show up to work or whatever, causing one problem, but a pattern. So doing this one thing multiple times to make a pattern, or more than one thing typically to make a pattern over a 12-month period, involving failure to fulfill major role obligations. That means, you know, not going to work, not paying your child support, not going to school, not picking up your kids after school because you're too high or hungover or whatever. Right? The things that you're supposed to do, you're not doing them. There's a use in situations where it's dangerous to use. Most commonly, this is talking about driving. So driving while intoxicated, but could also be, you know, if your work involves, you know, driving a forklift or working on a skyscraper and you're getting high doing that. That's abuse. That's bad. You have a problematic pattern of use. That's not recreational. You're not having you know, a whiskey with some friends at a party. Substance-related legal problems, so you're getting arrested, fined, ticketed, whatever for it, and continued use despite social or interpersonal problems associated with the use. Okay, so really it's just you have this pattern of use. It's causing some problems in your life, but criteria are not met for substance dependence, for at least this substance. If it is, then you don't diagnose abuse as well. It's kind of like dependence trumps abuse, because if you're diagnosed with substance dependence, it's assumed that you are abusing that substance. You have to abuse it to become dependent on it. Right? So people may initially be diagnosed with abuse, and then later go on to meet criteria for dependence, depending on when they're presenting. But you're not diagnosed with both for the same substance. For different substances, it's possible. You could be diagnosed with, you know, cocaine dependence and alcohol abuse. Right? So you depend on cocaine, you have withdrawal intolerance, and you're always getting high with that. But then you also drink sometimes, maybe to bring you down from your coke binges, but you haven't done that enough to where the drinking, itself isn't. You aren't spending lots of time recovering from that or doing that. You only drink a certain amount. Like you always drink a 6-pack of beer or whatever to recover, and the drinking doesn't really get in the way of many things, but it does cause you maybe some problems. So maybe you've had a DUI or two, or maybe somebody in your life doesn't want you to drink, but you keep drinking anyway, and that causes interpersonal problems. Right? Okay, and again, things you can't be diagnosed with: caffeine abuse. Hey, no such thing. Come on, everybody does it. It's fine. And also, interestingly, even though nicotine dependence is diagnosable, nicotine abuse is not. Which again, if nicotine were outlawed, you probably could have some substance-related legal problems. And I can imagine even without outlawing it, it could lead to interpersonal problems. If the person you're dating, in a relationship with, in a family with, doesn't like you smoking, it could cause some problems. But you can still do it. But again, a lot of people on the committee smoke, probably. So ain't no such thing as nicotine abuse. Right? Again, DSM is not perfect, folks. Okay, substance intoxication. Again, and when you're diagnosed with these things, hopefully you've figured this out, but I haven't said it explicitly. You're not just diagnosed with, oh, you have substance abuse. You have substance dependence. It's whatever that substance is. So if you're diagnosed with alcohol dependence or cannabis abuse, right? Whatever the substance is, that's what goes in front of the word. Same thing for intoxication. Phenylcyclidine intoxication. Okay. So the substance intoxication generally involves the development of a reversible substance-specific syndrome due to the substance. Right? So it's a pattern of symptoms that's reversible. It's not permanent. And the pattern of symptoms, the syndrome, is different for different substances. Maladaptive behavioral and or psychological changes due to the effect of the substance on the central nervous system are present and develop during or shortly after use. So what are maladaptive behavioral changes? Well, you become a jerk. Maybe you become violent. You become inhibited. You become really shy. Right? Psychological changes. You become really angry, anxious. You have changes in your sensations in terms of what you are able to hear, what you're able to see, night vision, depth vision, all those things, because those drugs are acting on your brain and your central nervous system, causing these problematic changes. Right? So, and some changes aren't maladaptive, as these drugs do. Right? Drink lots of caffeine. At some point, it increases psychological functioning. Right? Increases ability to sustain attention and alertness. But at a higher level, eventually it impairs concentration and leads to this kind of jitteriness. And that's when you kind of a maladaptive change. Right? So sometimes it depends on the dose that you're getting. Right? And so people may say, well, yeah, alcohol calms me down. And if we look at if we graft their psychological changes, at some point, alcohol may make them a nicer person to be around. For a little bit, 1 beer, 2 beers, and we go 3, 4. Now, not so much. Now we're getting into the maladaptive changes. Right? So it may be dose specific, and the symptoms are not due to a general medical condition or other mental disorder. Yeah. Okay. Example of substance intoxication in using the DSM for each of the substances. We won't go over all of them. Just kind of give you an example of each one. Alcohol intoxication. The behavioral psychological changes, for example, include inappropriate sexual or aggressive behavior, mood lability, which mood lability means your mood is labile, changes easily. Oh, I'm so happy, oh, I'm so sad. Impaired judgment, the phrase beer goggles comes to mind. Impaired social or occupational functioning, you're not able to do your job, obviously. And one or more central nervous system related symptoms, including slurred speech, incoordination, unsteady gait, the falling down, nystagmus, which is a persistent, rapid, involuntary, and oscillatory movement of the eyeball, usually from side to side, impaired attention or memory, and at high levels, even stupor or coma. Right? So poisoning your brain can cause all these effects temporarily. Right? It's reversible. Substance withdrawal, development of a substance-specific syndrome due to cessation or reduction of heavy or prolonged use. So people that stop cold turkey can have withdrawal. Most people that are trying to cut back and trying to reduce the amount can also lead to these withdrawal symptoms. But it doesn't. If you smoke one cigarette and then never smoke a cigarette again, not likely to develop withdrawal symptoms, right? It's after heavy or prolonged use. And it can be either of the two. So if you get super, super drunk and then don't drink anymore, you might have some withdrawal symptoms. Probably not real likely. But the prolonged use, even at moderate maybe levels, if you're using a substance for a long time, you very well could develop withdrawal symptoms. and then the syndrome causes distress or impairment, typically impairment, and it's not due to a general medical condition or there it is, other mental disorder. Okay. Again, an example using alcohol withdrawal. 2 or more of the following symptoms within several hours to a few days after the cessation or reduction. Autonomic hyperactivity. So this is racing pulse. So again, it's kind of the alcohol often kind of slows down autonomic activity. It's a barbiturate, right? So it calms, and so the withdrawal, you get the opposite. Increased hand tremor, which is the shakes people talk about. Insomnia, which is interesting because alcohol, although it makes some people sleepy, generally disrupts the sleep cycle when when drinking it. So intoxication, and also when not drinking it, if you've had heavier prolonged use. So alcohol definitely can screw up your sleep. Nausea or vomiting. Transient visual, tactile, or auditory hallucinations. So that sounds like fun, doesn't it? So people may, heavy drinkers that stop drinking, you may think, oh, this person comes in and you think, oh, I think they have schizophrenia, they're hallucinating, and you find out, okay, they've been drinking non-stop for 10 years, and then they just recently tried to quit, or they ran out of money, whatever, and so this is probably a temporary thing. This is just alcohol withdrawal, and these hallucinations may go away. Anxiety, and then also what may kill you, grand mal seizures. Right? Excuse me. So alcohol withdrawal potentially very dangerous, right? So people that are heavy drinkers, that's one of the big reasons when they go to treatment, if they go to detox, it's inpatient, right? You're being monitored by medical staff, so you don't die from not drinking, right? And not all substances have a dangerous withdrawal pattern. Many do, though, and so if you're working with clients, you want to make sure that they're educated about that and not just try to stop cold turkey on their own necessarily without the appropriate medical supervision. Looking at the substance-induced disorders, obviously other than intoxication withdrawal, because those are obviously caused by substance use. You could also be diagnosed with substance-induced just about any disorder: delirium, persisting dementia, persisting amnestic disorder, psychotic disorder, mood disorder, anxiety disorder, sexual dysfunction, and sleep disorder. So substances can really screw up a lot of things: your thinking, your memory, your ability to perceive reality, your mood, feeling calm, having sex, and being able to sleep. And you diagnose a disorder as substance-induced if, well, a couple things. One, potentially, if symptoms of the mental disorder are during intoxication withdrawal are exceptional, right? So, like I said, with alcohol withdrawal, you can have some hallucinations, and if you have that, it's not alcohol-induced psychosis; it's just withdrawal, unless their hallucinations are exceptional. They're really well developed, and they're acting with them for a longer period of time than what you typically see in alcohol withdrawal. If so, then now, okay, well, this isn't just regular withdrawal. This is alcohol-induced psychosis, psychotic disorder. Right? But you're getting into a very gray area because the guideline you're given is the symptoms are exceptional. So you really have to know what are the typical, what are non-exceptional symptoms in the context of intoxication or withdrawal for that substance. Okay. The substance can also potentially be the origin of mental disorder. Right. So you may have it in the context of intoxication withdrawal, or maybe you use the drug so much now you seem to have this disorder, and it was, it seems to be caused by this substance. And another gray area here, but you're looking at the temporal relation of onset and offset of use. So do you only have these symptoms whenever you use, and are the symptoms again not typical of what people typically have when using that drug, right? So you become manic whenever drinking alcohol. Okay, that's not typically what happens to people, so maybe that is an alcohol-induced mental disorder. right? So and then when you stop drinking and you're sober, you don't have those things. So you look at the onset and offset of symptoms compared to the onset and offset of use, and then also the excuse me, typicality of symptoms. Okay. It's important to kind of remember, though, that we talk about, using these drugs cause a disorder. And so far, really, with like the temporal onset offset, we're talking about, well, you have symptoms of a disorder when using, and and we're going to go ahead and call it, substance-induced mood disorder, because you seem to the symptoms are different than what other people have when using the substance. But it's not as though you're like other people that have a mood disorder, because if you don't drink, you don't use the drug, whatever it is, you don't have those symptoms. So it doesn't seem permanent, right? With the exception of the disorders that are persisting, and those are persisting dementia and persisting amnestic disorder. And that's maybe not surprising. If you use drugs long enough, you fry your brain, and you're not able to think clearly, and so you get dementia or amnestic disorder where you can't remember stuff. Not enough evidence yet for other disorders. A lot of people think that psychosis can result from chronic drug use, and marijuana being investigated as one of them, especially in people who may be susceptible to developing a psychotic disorder. That chronic marijuana use is kind of the stressor that reveals the diathesis, but not enough evidence yet to have a persisting psychotic disorder in the DSM. But that's something that may be coming, and we may also see that with other disorders one day, where we see people that have mood disorders, and they've stopped using drugs, but the mood disorder stays, and we think that etiologically the mood disorder was caused by this kind of chronic substance use. It wouldn't surprise me at all to see that. In terms of epidemiology, excuse me, important to remember that use doesn't always lead to dependence. Depends on a lot of variables, but one thing seems to be characteristics of the drug, and some drugs seem to be more prone to leading to dependence than others. And so we can look at the research that says, okay, have you ever used this, this, or this, and then are you dependent, yes or no? And from that we can get an idea of, okay, when people first people try something, how many of those people go on to develop dependence? And you kind of get, well, this is a highly addictive drug. So of the drugs that we've kind of mentioned, what do you think is the most addictive? And usually people say, oh, well, maybe cocaine or heroin, or maybe alcohol. Well, the winner is nicotine. Nicotine barely edges out heroin here. And then that's above cocaine, and then that's above alcohol. In terms of the average time between initial use and the development of dependence, again, you have to have at least a year. But typically, looking at the research, it takes about 2 to 3 years from people first start, think about the gateway drugs, and then it all snowballs. It takes a while. It's the slow progress, which suggests, to me at least, there's time to intervene. Right? If you can identify early problematic use before you meet criteria for a disorder and intervene then, maybe you won't develop the disorder. There are gender differences in rates of alcohol abuse and alcohol dependence, much higher for men than women, at least after 17. Until about age 17, pretty similar. After that, a big difference. And a variety of theories of why that may be. Maybe it's hormonal influences. Maybe it has to do with socialization and expectations surrounding alcohol use. But keep in mind, too, that women are much more likely to be diagnosed with a lot of other things, including depression. And so when we look at adults who are being diagnosed with things, adults that suffer from depressive and anxious symptoms, if they're women, they're probably more likely to be diagnosed with depressive or anxious disorder. And if they're men, they'd be more likely to manifest and to present in terms of alcohol abuse or dependence, because they are self-medicating, and because they're told not to talk about their feelings and not to feel things, so they may not report the mood symptoms and anxiety symptoms as much, and they may not even be aware of them. Kind of lack of self-awareness, essentially. In terms of what are the most prevalent diagnoses of dependence, again, the winner would be tobacco, which more common than alcohol, more common than cannabis, which is more common than cocaine or amphetamines. If you see cannabis there in the middle, like, geez, why is that that's higher than cocaine? But cocaine, look, cannabis is even on the top 4 of dependence. If people can't be that dependent that easily, how come it's so common? Well, because more people can afford to use cannabis than can afford to use cocaine, and so you see higher rates of dependence because use is more prevalent. Even though a greater percentage of people that try cocaine will become dependent on it, so many more people try cannabis that more of them become overall become dependent on it. Same thing with tobacco, readily available, and alcohol, legal if you're over 21, and so higher rates of dependence. Excuse me. Notably, abuse and dependence rates both decrease after young adulthood, so they kind of peak in what we think of as the traditional college years, and then they decline for a variety of reasons. You have usually increased responsibility in terms of work and family, and so it becomes harder to maintain problematic use. There's more negative consequences for getting drunk all the time or high all the time, and also people die. You know, if you're getting shooting up, your heroin every day, you're not going to live past 23 probably. So some of that dip is due to the cost of the methamphetamine use, and some of it is due to the big cost of death. In terms of comorbidity with other disorders, pretty high rates for a variety of reasons. Sometimes people, we see comorbidity because people are attempting to self-medicate. Sometimes the drug causes symptoms, right? So the drug will make people feel more anxious, and if a drug makes you feel anxious and you're biochemically stimulating the anxiety centers in your brain long enough, the brain is going to roll with that, and you'll start developing this tendency toward anxiety, perhaps more permanently. Then also, we may see comorbidity because symptoms of your mental disorder lead to social isolation, which is which increases your risk factor for use of a substance. And then also, kind of just the negative consequences of use. You know, people that are addicted to and dependent upon a substance often burn a lot of bridges and become socially isolated, to where the only people that are their friends are fellow users who would gladly steal all their stuff when they turn their backs. And not surprisingly, to see people that get that kind of socially isolated develop a sense of depression. Thinking about etiology, looking at just one class of substances, because in these factors that we'll talk about for alcohol abuse and dependence probably apply in many ways to other substances, but there are some differences, but we'll talk about just one example to kind of illustrate the overall structure. So we'll talk about social factors, including culture, which include cultural attitudes towards drinking and drunkenness, right? So for Muslims, there's no drinking, so very low rates of alcoholism, right? Same among Mormons, very low rates, because it's culturally not acceptable to drink at all. It doesn't mean they can't develop a problem, but much less likely to. Parenting playing a role, large in terms of modeling. So if parents drink or don't drink, if they smoke or don't smoke, more so than what parents say to their kids, it's what they do. Influences kids' attitudes towards drinking. And also parents who drink may give kids easier access to alcohol if they have it in the home. But the biggest predictor of biggest parenting behavior that predicts child use of alcohol is parental monitoring. So how much the parents watch the kids, know where the kids are, and leave the kids home alone, that predicts alcohol use. And low parental monitoring, if parents like, they're out with some friends, or we're going out, the kids are at home, they're not having a party, of course not, they're good kids, but they're not checking, those kids are more likely to use alcohol. But even more predictive of use of alcohol are peer, excuse me, peer and sibling influences. Much better predictor of substance use than parent alcohol use. If you don't know if kids are going to drink or not, find out if their friends are drinking. If their friends are drinking, yeah, kids are going to drink. Unlike a lot of other things, peers play a huge role. Biological factors obviously play a role. One thing would be the initial physiological reaction to the substance, right? So if you get a pleasurable sensation from using a substance, more likely to use it again. And that whether or not you get that pleasurable sensation is largely determined by your biology. Right? So we know that 30 to 50% of people with Asian ancestry will react to alcohol with flushed skin, nausea, and abnormal heart rate. So not surprisingly, because there's this kind of high rate of this negative reaction to alcohol, alcohol dependence is lower in people of Asian descent. Right? Excuse me. Genetics, like everything else, probably plays a role. Certainly has been even linked to level of social drinking. So people, even beyond kind of disordered, how much people drink alcohol socially, it's correlated with genetic influence. And also likelihood of disorder. And probably the role that genetics are playing have to do, again, with that physiological reaction, the metabolism of alcohol, maybe sensation-seeking, ability to inhibit impulses, and lastly, neuroanatomy and neurochemistry, the way your brain is wired, right? Typically, drugs affect the reward pathways in the brain, right? The mesolimbic dopamine pathway. We know that alcohol increases serotonin in the short term, and if your brain is wired to experience that in a very positive way, you may be more likely to be dependent on somebody who isn't. And again, where does your neuroanatomy and neurochemistry come from? Well, part of it comes from genetics, and part of it comes from experience. So we've talked about social and biological factors. Last would be psychological factors. Excuse me. Expectancy effects. People that expect alcohol to be awesome before they try it, more likely to finish. People think, oh, it's going to suck, right? And we know that we have some evidence from some placebo studies where we tell people, we're going to give you some alcohol, and then you're going to do some things, right? But we don't really give them alcohol. We give them placebo. We give them fake alcohol. And people with initially more positive expectancies of alcohol use more of it. Oh, this is awesome, and then they drink more, and they're all drinking the same thing, some flavored water. So what you expect about alcohol, which goes back to culture and family and peers, what people are telling you about it. And then there's also the tension reduction hypothesis, which says you drink to feel different, and usually to feel less anxious. Sometimes, arguably, to feel just less of whatever pain or emotion you're feeling. But the tension reduction hypothesis, that there's this tension, this negative affect, and you want to feel looser, less of that negative affect, and that's why you drink. And so people that become dependent are people who have a lot of tension, a lot of negative affect, and haven't developed appropriate coping skills to deal with that otherwise. And so the alcohol is rewarding not just because they're getting drunk and getting the kind of basic biological reaction, but because it's allowing them to not feel this other negative affect. It's not just to make you feel good, but to make you not feel bad. Okay. Another kind of factor in the theory is looking at attention allocation. We know that alcohol interferes with the capacity for controlled and effortful cognitive activities. You can't think straight, right? Which thinking about this can help you understand why drinking seems to make some people really happy and others sad. Happy drunks and sad drunks, right? And it seems that it's not necessarily a characterological thing, but an environmental thing, such that how you feel depends on the environment that you're in while intoxicated and kind of what's going on, right? So if you're in a happy place in drinking, all you can pay attention to is the happy stuff, and you won't remember any other bad stuff. And if you're in a sad, lonely, run-down bar all alone, getting drunk, you're going to feel sad, lonely, and run down, because that's all you can pay attention to. You can't think about other stuff. Which also might kind of point to drinking, the purpose of drinking behind developing dependence, as trying to distract yourself from ruminative thought. Right, so just trying to get out of your head because you can't concentrate, it's like, okay, if people are having this kind of obsessive thought about something, they think, okay, well, if I drink, I won't be able to think about it anymore because it's going to disrupt my cognition. And sometimes that seems to work. Unfortunately, more often than not, what happens is that, yeah, you screw up your attention, but now whatever the biggest thing you're worrying about is, you keep worrying about it, and you can't not worry about it because, again, you can't direct your attention elsewhere. Okay. Okay. That's all for now. Take care.